Welcome back to the deep dive. Sometimes the simplest infections can hide the most profound consequences. Today, we're opening up a file that is just a devastating case study in, well, medical misfortune. We're talking about how a run-of-the-mill sore throat can lead to decades of debilitating chronic heart damage. We're plunging into the world of rheumatic heart disease, or RHD. So, at its foundation, RHD is a chronic progressive destruction of the heart valves. It's not an immediate reaction, right? It's a late consequence, a sequela of acute rheumatic fever. And that's triggered by a super common bacterium, Streptococcus pyogenes, group A strep. While it might sound like an old world disease, it is still the major cause of acquired heart disease in kids and young adults globally.
And that global context is the core tragedy here.
Yeah.
RHD is absolutely a disease of socioeconomic disparity. It thrives in poverty and overcrowding, and most critically, where there's limited access to antibiotics. So our mission today is really to trace that specific horrifying link. How does a few days of untreated strep throat in childhood morph into chronic, life-limiting heart failure, say, 15 years later?
And we're not talking about a general heart issue here. The damage is incredibly focused. It specifically targets the valves. Our source material confirms the mitral valve is almost always patient zero in this, followed closely by the aortic valve. Okay, let's unpack this, starting with the fundamental cause. We need to be crystal clear. The bacteria itself doesn't, eat the heart tissue.
No, not at all.
This is the immune system attacking the host. It's the body turning on itself. How does that mistaken identity happen?
It happens through a mechanism we call molecular mimicry. This is really the foundational scientific concept for RHD. Think of it like this. The immune system, it's highly specialized. It recognizes invaders based on their molecular signatures. But in RHD, the signature of the attacker looks almost identical to a piece of the body's own anatomy. Specifically, the group A strep bacterium has this critical surface protein. It's called the M protein. And this M protein has evolved to share an antigenic similarity, the exact shape the immune system recognizes, with proteins found in our own heart tissue. The prime targets are cardiac myosin.
The muscle contraction protein.
Right. And the endothelium, the lining of the heart valves.
Wait, so the bacteria is essentially wearing a disguise that looks like our own heart? That's chilling.
Precisely. So when the immune system mounts its defense, it creates these highly specific antibodies and T cells to go after the M protein. But these immune agents are cross-reactive. They see the M protein and they see the cardiac proteins, and they attack both. This initial intense attack is the acute phase, and that's when we see it clinically as pancreatitis.
Pancreatitis, that's a dense term. For listeners, what does it mean practically when we say pancreatitis?
It means inflammation affecting all three layers of the heart. The endocardium, which is the lining and the valves.
Okay.
The myocardium, so the muscle itself, and the pericardium, the sac around the heart. In that acute phase, this can cause everything from heart failure to fluid buildup. But the real chronic devastation that starts on the endocardium, on those delicate heart valves.
It's truly tragic. The body's own defense system, which is supposed to be the perfect countermeasure, becomes the source of this profound long-term injury. The immune response is, it's the definition of collateral damage here. Okay, so we've established the acute chaotic immune battle. Let's fast forward. The body recovers from that initial inflammation. What does that acute attack look like years later when we look at the heart tissue? What's the structural footprint that proves this all happened?
Right. So we transition from acute inflammation to chronic scarring and remodeling. The signature marker of RHD is the Aschoff body. This is the pathognomonic lesion, the definitive microscopic sign of this whole process. There are these tiny granulomatous lesions deep in the heart tissue, and they contain these unique macrophages we call Anichkau cells. Seeing these confirms the rheumatic process occurred, but the Aschoff bodies, they're really just indicators of the initial damage. The functional problem comes from the healing process.
So the body tries to heal the valve leaflets that were attacked, but that healing goes horribly wrong.
Exactly. Instead of healthy, flexible tissue, the healing involves extensive fibrosis, scar tissue and calcification. And this sets the stage for all the chronic features. The valves thicken, the corners of the valve leaflets fuse together.
The commissures.
The commissures, right. And the chordae tendineae, the little ropes holding the valve, they shorten and thicken.
Here's where it gets really interesting. Focusing on the specific outcome of all this scarring. If the mitral valve is the primary target, what's the structural abnormality we see most often, and why is it so devastating?
The mitral valve is, without a doubt, the most vulnerable. And the chronic lesion we see in, well, something like 99% of established RHD cases is mitral stenosis. MS stenosis just means narrowing because of that rampant fibrosis and, crucially, that fusion of the valve commissures.
Hmm.
The valve opening just shrinks dramatically.
Hold on, you mentioned the fusion of the commissures and the shortening of the chordae tendineae. Does that restriction mean the valve can't open fully or it can't close fully, or both?
Primarily, it can't open fully. Imagine those delicate little ropes become thick, fused cables pulling too tight, and the corners of the door are essentially glued together. You're left with a small, stiff, centralized opening. This is what gives the leaflets that characteristic restrictive appearance. Classically, it's described as the fish mouth or buttonhole lesion. It's not a flexible door anymore, it's a funnel.
And that structural bottleneck has immediate disastrous consequences upstream. The mitral valve sits between the left atrium getting blood from the lungs and the left ventricle, the main pump. If that valve is stenotic, narrowed, blood has to back up severely.
It does. The left atrium has to work so much harder against that narrowed opening, which leads to left atrial enlargement. A stretched out atrium is electrically unstable, which is why patients so frequently develop atrial fibrillation.
AFib.
AFib, a chaotic and dangerous heart rhythm. And this backup eventually pushes pressure back into the lungs, causing life-threatening pulmonary hypertension.
And while mitral stenosis is the star of the show, so to speak, we should briefly touch on the aortic valve.
Absolutely. The aortic valve is the second most common site, and often RHD is a combination disease. If the aortic valve is involved, it often results in a mix of aortic stenosis and aortic regurgitation. The tricuspid valve on the right side can also be affected, but that's usually secondary. It's a consequence of the severe pulmonary hypertension, not a primary rheumatic attack.
This disease it's a slow, quiet killer, as you said. When do patients actually start feeling symptoms? It's not right after the strep throat, is it?
No, and this is the most tragic part of the whole narrative. There's a critical latent period. It can last 10, 15, even 20 years after that initial childhood strep infection that's often forgotten. The patient feels totally fine while this progressive fibrosis is silently choking off the valve. Symptoms only appear once the stenosis is severe enough to just overwhelm the heart. They reflect advanced heart failure, lung congestion. So when they present, we hear complaints of dyspnea, on exertion breathlessness with minor activity, and signs that fluid is shifting, like orthopnea, paroxysmal nocturnal dyspnea.
Waking up suddenly short of breath.
Exactly. Palpitations, often from that underlying AFib, are common, and just general fatigue.
I know for clinicians, the physical exam kind of provides the soundtrack to this pathology, especially for mitral stenosis. What are the classic signs?
Oh, the physical exam is classic. You're listening for a very distinct triad of sounds. First, a loud S1, the first heart sound. That's from the forceful delayed closure of that stiff valve. Second, an opening snap. It's the audible noise of the rigid valve suddenly hitting its maximum opening point.
Yep.
And finally, the characteristic mid-diastolic rumbling murmur. You hear it best at the apex of the heart. That's the sound of blood jetting turbulently through that small fish mouth opening.
Those physical signs point us in the right direction.
Yeah.
But to confirm the severity and plan what to do, we need a picture. What is a definitive way to visualize all this?
That is where echocardiography comes in. It is absolutely the diagnostic gold standard for RHD. It's like an X-ray that can see tissue in motion. Echo allows us to directly visualize the valve structure. We can see the thickening, the fusion, the shortened chordae, the full morphological picture. And more importantly, we can measure things. We calculate the valve area, which directly tells us how severe the stenosis is, and we can quantify how much blood leaks back if there's regurgitation.
And for supporting evidence, what are we looking for on an ECG or a chest X-ray?
On the ECG, we're looking for signs of that stress we discussed. So atrial fibrillation, or a specific pattern called P-mitrol, which is electrical evidence of that stretched out left atrium. The chest X-ray is useful for revealing the bigger consequences, like the general left atrial enlargement and clear signs of pulmonary congestion, fluid in the lungs.
And if this is left unchecked, the consequences are devastating. We talked about AFib, but what's the immediate life-threatening risk that comes with that?
The immediate risk stems from that AFib causing blood to pool and clot in the enlarged left atrium. That forms a left atrial thrombus. Once that clot forms, there's an exceptionally high risk of systemic embolism. The clot breaks off and travels.
And that often means a stroke.
In the vast majority of cases, yes, an acute ischemic stroke. Add to that the progression to right-sided heart failure and the fact that these scarred valves are highly susceptible to getting infected themselves, a condition called infective endocarditis.
So what does this all mean for treatment and, more importantly, prevention? Since this disease is so rooted in socioeconomic factors and a simple infection, prevention has to be our most powerful tool.
Absolutely. The management of established RHD follows two tracks. Medically, we manage the symptoms, diuretics for congestion, beta blockers, and critically lifelong anticoagulation if the patient is in AFib to prevent that catastrophic stroke. If the stenosis is severe and symptomatic, we have to intervene structurally. Sometimes we can use a balloon procedure, a percutaneous balloon mitral valvotomy, to basically force open the fused leaflets. But if the valves are too scarred or calcified, the only option is open heart surgery for a valve repair or total valve replacement.
That's the tertiary care side, managing the damage. But the real public health victory has to be in prevention. Our sources talk about primary and secondary prevention.
Primary prevention is common sense. It's just prompt, complete treatment of strep throat with antibiotics in the first place. Eradicate the strep, you eliminate the trigger, simple.
But the challenge there, as you said, is the social context.
Yeah,
Access, cost, finishing the full course.
precisely. And that's why we put so much weight on secondary prevention. This is the absolute cornerstone of controlling RHD in high-risk populations, people who have already had at least one episode of acute rheumatic fever. Secondary prevention means long-term, scheduled administration of benzathine penicillin G, typically a large, painful intramuscular injection given every 3 or 4 weeks for years, sometimes decades. We cannot overstate its importance. It prevents the recurrence of ARF episodes, and every recurrence causes more cumulative, irreversible valve damage. This long-term penicillin prophylaxis is the single most effective tool we have to stop the progression of RHD.
The insight here is incredible. A small investment in penicillin delivered reliably is this massive public health barrier against debilitating, incredibly expensive cardiac surgery 15 years down the road.
Yeah.
That connection, the M protein triggering an immune cascade that requires decades of preventative penicillin, that's the entire story encapsulated.
It is. If we distill everything down to the essential pearls for you, remember these points. The mitral valve is the most common target. The lesion is mitral stenosis with that fish mouth appearance. The pathogenesis, molecular mimicry. Our diagnostic gold standard is echocardiography, and the cornerstone of public health is secondary penicillin prophylaxis.
And the prognosis for anyone with this depends entirely on the severity of that damage and how early we intervene. The progressive, fibrotic nature means untreated RHD leads relentlessly to progressive heart failure and a significantly reduced life expectancy. It demands attention.
And thinking back to the core mechanism, molecular mimicry, it raises a fascinating and maybe provocative thought for you to consider. If our body's defense against a simple strep infection can accidentally trigger chronic damage, what other common, seemingly benign infections might be silently setting the stage for chronic autoimmune diseases, affecting the joints, the brain, the kidneys, years or even decades down the road?
Something to mull over as we all head to the doctor for that sore throat. Thank you for diving deep with us today.